reform is an issue I've been working on since 2009. That's before the Affordable Care Act, that's before President Obama. This is a $30 billion issue in Medicaid. And rather than focus on the $2 billion question, I'm focusing on the things that I know are in front of me. The growth of Medicaid, the $30 billion Pac-Man, as it's been referred to, is happening now. I'm working in the now.
So you would cap, can you explain it? You would cap growth per member?
We aren't capping growth. We are setting targets and shared goals for the rate of growth of the per member, per month rate in Medicaid. That is important. That is something the state can control. That directly impacts healthcare costs. So the input costs and the negotiated managed care contracts and all these other things the state has the ability to control, that is the per member per month rate. We can't control the economy. I can't tell you how many people are going to be on Medicaid in a year, because if the economy improves, we'll have less people. If it doesn't, we'll have more. But the per member per month growth rate is something that we can set targets on, negotiate, and work towards.
How much was the administration involved in drafting the bill?
I would say they weren't really involved in it directly in terms of the input in the legislation itself, but conceptually, they're on board with this. When we last met with them, they liked the ideas. The way that I had initially presented it to them, they thought that we had a workable plan, and they were willing to build a relationship with the General Assembly to have a shared vision. And I certainly applaud them for that. That is a rarity in this body.
For the person that's on Medicaid, how is their care and coverage going to change?
Well, I would say that it's going to add a couple things. When we go back to the first graph, I think one would have a hard time arguing that that's a stable growth environment for Medicaid. It technically puts the entire system at risk, as it nears what eventually could be 100% of the state budget. Secondly, because we're focused on health outcomes, we're now going to use evidence-based, measurable directives rather than things we think work. We're actually going to use policy that does work. So we should see an improvement in overall health care within the Medicaid system. Hopefully, return folks to a workable or improved workability type state and allow them to participate more fully in society. That is a goal that Medicaid should have, a hand up, not a handout. And I think when we talk about health care, it's tied right to education when it moves up the socioeconomic ladder, and we want to focus on that.
You talk about the cost containment targets. What happens if the actual growth is more than that? What power does this authority or oversight panel have to change the program to bring those costs back down?
Well, I suppose maybe to some people's surprise, Director McCarthy is not going to jail. It is an objective that we are openly stating publicly, one that will be renegotiated on an ongoing basis based on the medical rate of inflation and other input costs. But again, it sets a target that we openly say to the public, we are going to move spending in this direction to be no more than. And if we're not able to achieve that, we'll be publicly accountable as to why that didn't occur. Which again is a different concept than saying, thou shalt spend no more than $17 billion. That has led you to the issue that we have today. And again, just making a simple statement. The difference between the projected Medicaid growth in the fact book, averaged together for the known years up and coming, are about 4.59%. Our plan is 3%. Now, what difference does 1.59% make? It makes $8.5 billion difference by the time we get to 2020. I think that is a worthy objective, and I think the citizens of our state will want to hold us accountable to achieving those outcomes.
But what happens if we miss the target, other than saying we missed the target?
Well, again, nobody's going to jail, but we are accountable for that. I think that is a much higher bar than saying I'm not going to spend more than $17 billion a year.
Accountable to who? The voters?
The voters, and as well in this bill, don't forget, we're measuring health outcomes as well. So we're setting goals not only within fiscal policy, but within healthcare policy.
Senator, going from 4.6% down to 3%, I mean, that's, by my quick math, I mean, that's at least a 30% reduction. I'm just not getting, I guess, how does that happen? I mean, and why isn't it happening now if it's something that we can
It
just say?
is happening now. For those that are familiar with the fact book produced on behalf of the Medicaid department, if you go to page 15, you have a historic look at the growth rate in Medicaid. And to be honest with you, the per member per month rate, not all funds spending on the grand budgetary item, but the per member per month growth rate has been reasonable. It's actually been around 3%, if not less. In some years, actually negative. When we look forward, that growth rate is not continuing. That's what troubles me. So hopefully the economy will improve and we'll have less recipients on Medicaid. That's a hope. I can't control that. But I can control the rate of growth. And I think maintaining current efforts and building on previous successes in an evidence-based way will allow us to continue the current growth trend rather than see it move up as projected.
Can you say